All right, COPD. There used to be 3 COPD diseases. Now there's only 2. Asthma was taken out. Asthma is now a allergic or hypersensitivity disorder, although it still applies to, I mean, it still affects the respiratory system, but it's now categorized as a allergic disease. COPD. So we have 2. We now have emphysema and chronic bronchitis. These 2 are not the same. They are 2 completely different diseases. Both, though, have cigarette smoking as the primary cause, although it's not always COPD. Okay, it's not only smoking, because there are non-smokers that have COPD. So the other causes are the following. So we have exposure to air pollution, secondhand smoke, and a small case, which is 5%, is a deficiency of this syndrome, I mean this enzyme right here. So what happens is cigarette smoking is a pollutant, right? It's an irritant. So whether it's cigarette smoke, first-hand, second-hand smoking, doesn't make a difference. Or exposure to dust and chemicals or any other pollution, all these trigger a inflammatory response in our respiratory tract. So this increases the mucus production in order to trap the pollutant. Um, and there's also a natural enzyme produced by the respiratory tract. It's called protease. Protease will break down any debris that enters the respiratory tract. So since we're not inhaling sterile air, we're inhaling polluted air. Everywhere we go, we breathe in bird poop, pieces of dog poop, cat poop. So we're exposed to debris all the time. But don't worry, we have protease to the rescue. So protease will break down any debris. However, something has to stop the production of protease. Let's say you come home, you have less pollutant exposure already. So therefore, there has to be a negative feedback. That negative feedback is alpha 1 antitrypsin. So this is the other enzyme that will stop the production or the release of protease. So let's say you're out let's say you work outside. You are a contractor for Con Ed, so you drill holes to bury gas lines, for instance. So you're exposed to a lot of pollution. So when you get home, so the whole time you were working, your protease were very active. So they were constantly trapping and breaking down debris, any pollutant. However, when you come home, since there was no more exposure, okay, you're breathing in clean air now. However, if you still have protease present, then that will now, the protease is designed to break down something. They have to, destroy something. So if they have nothing else to destroy, they will now start destroying your lung structures. So they'll start destroying your upper airway all the way down to your lungs. So we have the other enzyme, alpha 1 antitrypsin, which is now released because this is now the negative feedback. We have to stop the protease. So in some people, in 5% of all COPD cases, they have a deficiency, a genetic deficiency of alpha 1 antitrypsin. They don't have it. So therefore, when deficient, it will result in emphysema because it will now leave protease with uncontrolled, unchecked activity, wherein if they run out of foreign debris to break down, then they'll start breaking down lung tissue. Okay, so that's the and there's actually more than we think. Okay, so look at this: about 100,000 Americans have alpha 1 antitrypsin. So therefore, this is the small number of people who develop COPD with no first-hand or second-hand smoking history. So here is the differences between um, a patient with normal lung versus emphysema. So here we have destruction of the alveoli walls here. So instead of your alveoli being individual grapes, okay, they're supposed to be individual air sacs like this, separated only by thin membranes, and each one is wrapped with a capillary network. So it's not shown here, but every one of these microscopic air sacs are wrapped in a capillary network. Okay, so that's where gas exchange occurs. So in a patient with COPD, so whether it was the smoking or the protease breaking it down due to alpha 1 antitrypsin deficiency, they destroy lung structures. So instead of them being separate like this in the being individual um, grapes, now they become one consolidated hyperinflated structure. Okay, so there's no more individual air sacs. So what will happen to gas exchange now? So if it's as air enters here, and then there's no more alveolar walls to speak of, they're now enlarged, they are hyperinflated, so they can no longer contract, they can no longer uh, expand and recoil. Okay, so they enlarge and lose elasticity. So this is now where your carbon dioxide gets trapped, because in a normal alveolus, air enters in, and so air is 21% oxygen, right, and then about 70% nitrogen. So there's gas exchange here along the capillary wall. So oxygen is traded for CO2 via diffusion, movement of solutes from an area of higher concentration to an area of lesser. So gas exchange occurs passively between the alveolus and the capillaries. Okay, so oxygen goes in, diffuses in, and then CO2 diffuses out. This is no longer possible here. So, and although oxygen enters, however, once oxygen enters in and then CO2 is given out, this damaged alveoli or network of alveoli cannot recoil, are not elastic anymore. So can they expel CO2 out if they are now weak and lose elasticity? Unlike these guys here, when these guys contract, they will push out, literally they'll push out CO2. That's how we do exhalation. So can these guys exhale effectively if they have emphysema?
No, you can't
No
push it out.
more. Okay, so the alveoli here become hyperinflated, and then multiply this by 20, 30, 50 million of them, of these damaged alveoli. So now your lung will look hyperinflated. So this will be chronically hyperinflated, and there will be several consequences there. For one, there will be a lot of air trapping. So that's why you learned in fundamentals that COPD patients are CO2 retainers, right? They retain CO2 because of this problem. The hyperinflation now will change the shape of the chest. So being normally, if you look at your chest wall, it's supposed to be longer, um, longer diameter from here to here compared to from your posterior to anterior diameter. Okay, meaning between your spine and your sternum, there should be a 1:2 ratio, meaning the diameter of your, meaning the distance between your spine and your sternum should be half the diameter between from your left axilla to your right axilla, right? That should be the shape 1:2. Now in COPD, if we hyperinflate the lung, that will now cause the entire diameter of your torso, your thoracic cavity specifically, now becomes barrel chest. It becomes a perfect circle, almost a perfect circle. So that means there will be less area for gas exchange, and also your heart will have a higher workload now, because now it has, so when this is hyperinflated, meaning there will be greater resistance now. So this is harder to perfuse compared to this one, because this one will recoil, this one won't recoil. So there will be now increased resistance. You can call it afterload. Okay, there will be increased afterload on which side of the heart, the right or the left side? Which side of the heart pumps blood to the lungs?
The right side.
The right side. So the workload of the right side now increases because now they have higher afterload or higher resistance to pump blood into the hyperinflated lungs. So therefore, the patient will go into heart failure, right side heart failure, known as cor pulmonale, COR, and then pulmonale is PULMONALE. It's basically right-sided heart failure, but we call it something else because this type of right side heart failure did not result from a cardiac disease. This one resulted from a pulmonary disease. So that's why it's called something different. But signs and symptoms that result is basically the same as what we learned in heart failure. So heart failure, right side heart failure, is exactly what develops here in emphysema. Um, However, we call it cor pulmonale because again, the resulting right side heart failure was caused by a pulmonary hypertension problem, not coronary artery disease, not a valve disorder, not an a electrical conduction problem. Are we clear so far? Okay, so that is for emphysema. Now, the chronic bronchitis is involving the upper airway. So, in chronic bronchitis, it is now chronic inflammation of these large airways here. So, starting from the main stem bronchus down to the right and left. So, the same exact causes, still from smoking, still from irritation, or it could still be from alpha 1 antitrypsin deficiency. So, chronic bronchitis results from chronic exposure to these allergens, to these irritants, causing increased production of mucus. So therefore, if you have increased production of mucus because there's constant exposure to smoke, for instance, to the cigarette smoke, so that will cause the cells also that produces those mucus also enlarging. So they become hyperactive, enlarged, and at the same time there is also damage to the cilia that propels the mucus upward, and then add to that the protease activity, which will now damage the bronchial walls. So all of these combined will cause chronic bronchitis or chronic inflammation of the airway. So this could develop in the same as emphysema. These two conditions develop over several months, several years, several decades. Question so far? Okay, so please read the rest here. That's the explanation. Let's look at now the.
Professor?
Yes, sir.
Oh, where you said that they develop different months, years, and decades basically you're saying that it could develop as short as a few months, or it could take as long as a few decades.
Well, the damage has to start somewhere. So yes, the damage occurs over several months first, and if the patient doesn't stop smoking, then it will continue to develop. So you'll basically damage one section, let's say this lobe first, and then another lobe next. So it's just a matter of how much of your lung you damage over time now. But regardless, every exposure will cause some damage. And if you don't stop smoking or stop the exposure to the irritants, then there's no chance for the lung to recover. So, as more of these are formed, these are now permanent changes. You cannot fix this. So, let's say this month you damage this area, they'll be permanently damaged. You see what I
Oh,
mean?
yeah.
Okay, so and then that just multiplies. The longer you smoke, then the more of these structures you damage, and it's just a matter of how much of the lung you have left, and then you start having symptoms.
Oh, okay.
Okay, so these are now your symptoms. So I mentioned the change of the barrel chest. So here, so this is expected. Now we need to distinguish between what is expected and what is a sign of an exacerbation, because this is a chronic condition. So the patient will have to live with this every day, meaning we don't necessarily have to call the doctor for each of these changes because these are now the patient's new normal. Because of the damage to the upper and lower airways here, and even the lung, in both cases, chronic bronchitis and emphysema, the patient may have one or both. Okay, the patient may have chronic bronchitis only, or the patient will have both chronic bronchitis and emphysema. So barrel chest is the normal change, so that's expected. No need to be alarmed about that. Another is the reddish tinge um, to the skin. They look red for some reason. Um, we call them pink puffers because this problem is a in response to the hypoxia that results, they develop polycythemia. However, these red blood cells are normal though. These are normal red blood cells that are increased in number, so they are capable of carrying oxygen. The problem is just that we don't have enough, oxygen. So the body responds by, well, if I can't get enough oxygen in, maybe I can increase the oxygen carriers. Okay, so again, you have a less supply of oxygen, but then if you create more delivery trucks to carry the oxygen, maybe that will improve it better. But of course, that doesn't happen because your supply remains low. However, because of the increased number of red blood cells, then the patient appears red. There are also patients who appear blue, so they are more cyanotic. Okay, so these are the patients that um, don't have that polycythemia compensation. Okay, so these patients retain high levels of CO2, and then they appear cyanotic. Just like sickle cell disease, asthma, cystic fibrosis, rheumatoid arthritis, lupus, any chronic condition for which there is no cure will have good days and bad days. Patient will have a bad day with COPD as well. So let's say they decompensate, all right, or let's say they stop taking their medications, or they either have an increase in the amount of their day-to-day pollutants, or if they get sick. Usually the trigger is if they have a upper respiratory infection, meaning they have another trigger, another insult on top of the daily insults they have. So this will result in an exacerbation, meaning they will have an increase of these symptoms that they're having. The shortness of breath will increase. The amount of CO2 that they have will increase, okay, because they're exposed to a hypoxic episode, such as the cold or the flu. So these are usually the common triggers. So these patients are again chronic diseases. So they will be your regular customers. So every winter, you'll see these patients being admitted because it's getting cold, so they get the cold virus or they get the flu, for instance, and then you'll see them in the hospital because they cannot um, breathe normally, in their normal new normal day to day anymore. Okay, they have an increase in hypoxia, an increase in hypercarbia. So this is a variation of the patient's baseline day-to-day of the symptoms. So there's an increase now. So these patients have to be admitted to the hospital. These are your warning signs. So if the patient has these, it's time to call their doctor. If they call early enough, they may avoid hospitalization because the doctor will just either increase their dose of medication or give them a steroid, um, on top of treating the cause, of course. Let's say they had early symptoms of the flu, they have these increasing symptoms, they call the doctor, test them for flu, they turn positive, they'll be put on Tamiflu, for instance. So in that early stage, we can shorten frequent or severe cough. Then if they call ahead, they can avoid hospitalization. Here is a side-by-side comparison. Asthma is still here, but as you can see, the symptoms are the same. In fact, the treatment is the same. When we go to medication, we will actually go back to asthma. It's in a different page. Here, unlike asthma, here asthma is reversible, okay, because this is an allergic disorder.
I don't see anything, Professor.
You don't see what?
I don't see your screen.
The whole time?
I see it.
I don't see it. You see it? Okay.
Maybe you're looking at a different. Who's
It's
this, Sheila?
just no, Vivian. It was just now.
Oh, maybe it's just your internet connection, maybe.
Okay.
Okay. All right, management. Let's do the diagnostic test first, and then we'll go to treatment, which, as already mentioned, is in the asthma section. So, how is the patient with COPD diagnosed? And the doctor will also grade them. Okay, so there will be stages or grades of COPD. The grading and staging is still based on the same thing. It's based on FEV1. So this is forced expiratory volume in 1 second. Yes, we also measure FVC, but the true measure here is really the second one, the forced expiratory volume in 1 second. So how they do this is they use spirometry. Now, do not confuse this with incentive spirometry. Okay, incentive spirometer is the small device you give to patients, right? And they inhale through it. It expands their lungs and prevents lung collapse, prevents pneumonia. All right, that is a at the bedside. This spirometry is not in a hospital. It's only found in a clinic, unless the doctor's clinic is inside a hospital. Then that's the only time you see it in the hospital. So spirometry is a bigger machine. It's a huge machine, like the size of a washing machine. Okay, and it has hoses coming out of it. So the patient will be asked to perform several um, maneuvers. So the patient will be asked to, in some cases, they'll be asked to inhale. In some cases, they'll be asked to exhale. Okay, when they're asked to inhale, we're measuring, or the doctor is measuring um, total lung capacity there. And then we also have forced vital capacity and even forced expiratory volume in 1 second. This is now the blowing part. So the doctor will ask the patient uh, to blow as hard as they can. They'll do this a few times. Of course, the patient has to rest in between. And the highest volume exhale is recorded. So if their FEV1 is lower than normal, then that means the lung, due to these damages right here, this damage here, will weaken, meaning the forced expiratory volume, of course, will decrease, because again, if the alveoli are shaped like this instead of these, can they expel CO2? Yes,
No.
or can they expel air? No. So with the more of these, we call this bula or bule, plural bule. These are now pretty much they're dead, you know. Well, they're not necrotic, but they're pretty much useless parts of your lung, because they can now no longer participate in gas exchange. Okay, they're done, right? They're damaged permanently. So the more of these you have, then the weaker your lung becomes, the less air you are able to force out in 1 second. Okay, so that's how they measure the severity of your COPD. So the lesser your FEV1, then that means they can just imagine how many of your alveoli are already damaged. That makes sense? Are you following so far?
See.
Yes.
Okay, all right. So that's diagnosis. Here is, let's look at, what page is this? 484. Let's look at what this table says. Okay, here. This is not testable. Okay, I'm just showing you how it would look like. Look at the severity. Mild, so you still have 80%. Okay, that's still good. I mean, that will still allow you to do your daily activities with probably little to no um, little to no impact on your activities of daily living. And then it goes down from there. So now you have 79%. So that's now moderate, severe, 30 to 49%. So you're less than half now. So of course, these patients will present like this, right? Even at rest, they will have shortness of breath already. This one, still, as long as it's still half, they'll probably be symptomatic with normal activity. Okay, but then they'll rest, they'll fine. These guys here, um, in less than half, they're operating less than half. So these patients, even with less than ordinary activity, they'll be short of breath. And gold 4, these patients are bedbound. There's no way these patients can even get out of bed. Okay, these patients are already waiting for a lung transplant. All right, so let's go to treatment. This is the summary right here, but the treatment is in the asthma section. So let's go to okay, not asthma, but drug treatment for asthma. Let's start with the peak expiratory peak flow meter. Sorry, right here, box 26-1. So question on the exam will be how to use it. You won't believe how many people don't know how to use this. So this is given to patients with asthma and COPD. This is not a treatment tool, diagnostic tool. They carry this home, so they're given one. These are disposable things. So I don't have a picture, but anyway, it looks like um, what is that thing you we play with that sounds like it like that?
Flute.
What?
Yeah. Accordion.
No,
Accordion.
it's
Flute.
it's just a small one you hold in your hand that makes a really this annoying sound.
Oh, the thing you use for
Kazoo?
like New Year's?
Yeah, what do you call that?
I don't know.
A kazoo? Is that it? Is it called a
Yeah. Mm-hmm.
what's it called again?
A kazoo.
Yeah, yeah, whatever that is. So it's shaped like that. So it's a small device and it has numbers in it. So this is how you use it. So it's a measuring device called kind of like a miniature incentives barometer. Okay. So you slide the marker down to zero. So you zero it first and then you do this several times. So let's say if this is the first time you're doing it. So you have to establish your baseline peak flow. You can't do this when you're sick. So you have to be feeling well when you do this. So we establish your peak flow. Let's say you have just been admitted, I mean, diagnosed with COPD. So doctor or the doctor's nurse gives you this. So stand up straight, and then exhale, and then take a deep breath as deep as you can, and then blow as hard as possible. So fast, hard blast. So you do that um, a number of times. You do that now, and then you rest. Several minutes later, you do it again. So we record the highest peak flow you made. So that highest one, which again, the key here is you do this when you are well. We can't do this when the patient has symptoms because that won't be your baseline. So we need it to be your baseline that you are feeling well. So once we know your peak flow, so let's say your peak flow is 350 mLs. So you're able to blow 350 mLs of air at any given time. So when the patient has symptoms, we base it on the peak flow. So let's say the patient has cough today. They have extra cough, all right, more than usual. So they grab their peak flow meter and they blow into it about 3 times, and then they record the highest number. If that peak flow is less than their baseline, then that means they are having an exacerbation. That's when they call the doctor. However, if they blow into it and then it's at or even higher than their baseline peak flow, then that cough, whatever they're having symptoms of, is not from COPD. It's not from asthma. It is from something else. So it's probably a upper respiratory thing, okay, or the flu, for instance. But still, they have to notify the physician. That way, they get medicated. But at least the doctor will know that we don't need to increase your steroids, for instance. Okay, we don't need to make adjustments there because right now you're doing well. Your peak flow is okay. We just need to treat whatever is causing your symptoms. Are you with me so far?
Yeah.
Okay,
Yes.
so this is the use of a peak flow. Um, it's not for treatment. It's not for it's nothing therapeutic. This is only to help us diagnose what's causing your symptoms. Okay, are you having an attack? Are you having an exacerbation? So please follow these here, the directions. All right, let's go now to treatment. It's not really different from anyone else. Like say you're taking care of a pneumonia patient, somebody with a flu. So our standard respiratory assessments apply. With the medications though, I won't test you on this one because this is now the regimen. Okay, we don't do that. Let's just go with the medication. So doctors take care of this. Although as a nurse, you will learn that, but it's on the job. Okay, not before graduation. All right, medications. So these are the standard ones we use. We use anti-inflammatories, or those are your steroids. We have bronchodilators, which we have two. We have SABA, which are your short-acting or your rescue inhalers. Then we also have your LABA, which are your long-acting or your maintenance bronchodilators. Okay, so these are the drugs you use. So give me an example of a SABA, a short-acting bronchodilator.
Albuterol.
Okay, very good. Albuterol or levalbuterol. It's a beta adrenergic agonist right here. They are beta 2 adrenergic agonists, meaning this is the opposite of a beta blocker. A beta blocker will stop the adrenal hormones, right? These drugs are going to be to promote the effects of adrenal hormones, meaning if epinephrine causes tachycardia, increased heart rate, and vasoconstriction, it will do the same. So when you constrict the vessels in your airway, it actually enlarges the bronchus, the bronchial wall, the bronchial diameter. Can you picture that? Meaning, think of it this way: the walls of your bronchial wall, these muscles here, they're muscles. Okay, so your airway is a muscle. The walls of that muscle can constrict and can dilate. If you constrict the vessels, so just like in a penile erection, for instance, so when a penis gets an erection, why did it erect? Why did it turn hard? Is there a bone in there?
The hormones.
Vasodilation.
Okay, so there was increased blood flow to it. That's why it enlarged. So same exact thing here. So the bronchus is also a smooth muscle. It has vessels in it. So if you dilate those vessels, what will happen to the bronchial wall? It will enlarge and thicken. Therefore, when the walls are now thickened, what happens to the diameter of your airway? Will it narrow or will it widen?
I guess narrow.
It will narrow because now the walls are very thick. However, if you have a beta 2 adrenergic agonist, which causes increased heart rate and vasoconstriction, it will constrict or widen the diameter of the bronchial wall now, because now all those vessels are now constricted, so therefore the walls now are thinner, widening the airway. Does that make sense?
Yeah.
Okay, all right. So that's how they work. However, because they are beta 2 adrenergic agonists, your number one side effect is tachycardia. The patient will have palpitations, okay, as a result. And because especially your sabas, um, they are used several times a day. You know, every time you have an attack, you grab it, right? So you may tend to have too much of it, and then may cause, instead of just having sinus tachycardia, you may have a more dangerous dysrhythmia now. Okay, so that's one side effect. Then we have the LABAs, which are longer acting. These drugs don't work like your SABA. Okay, they are for long-term use. By long-term, I mean this won't help you in an emergency. These are only used for um, long-term control. Okay, so um, they're not of any use to you. If you grab that during an emergency, you'll die before this thing takes effect. Okay, so you're still stuck with your rescues or your sabas. Okay, so make sure your patient knows to carry them where they go. We have inhaled steroids. These come in either powder or meter dose inhalers, because they're steroids, so they're anti-inflammatories. So they're also not used for short term. Okay, these are again long-term purposes. So your LABAs can be steroids as well. Okay, there are LABAs that are steroids. We'll go to the, there's no list here. Maybe they're in the, where did they put them? 477. No. No, that's for hyperkalemia. This is what I don't like about your textbook. That's why I'm going back to Elsevier in the fall. Because you're actually missing a few details about, especially with drug therapy. Anyway, you did discuss these in pharmacology, right? I hope you did. Yes, no.
Yeah.
Okay. Where was I again earlier? For I'm lost now. Okay, we're here. Okay, that's a peak low. Okay. So we discussed the SABA, LABA steroids. Okay, let's go to leukotriene inhibitors. Where is it? Oh, right here. Drugs like Montelukast, or what's the brand name? Singular. These are daily PO medications. They're taken usually before dinner, around early evening. This is a different class. This is a new breed of medications used for both asthma and COPD. They're long-term. Okay, they're long-term asthma control, and they're especially beneficial because they're not steroids. They only target leukotriene, which is the number one. This is a antihistamine, okay, which is responsible for the symptoms in asthma and COPD. So this is an inflammatory substance that causes the inflammation and therefore the shortness of breath and the other symptoms that are common in COPD and asthma patients. So by taking this, no, it only targets one particular antihistamine, only leukotriene. Okay, so this will inhibits this activity right here. So since most of your symptoms are caused by your own immune system, so this will be extra helpful with no resulting. There's really no broad inhibition like those of corticosteroids, because corticosteroids are not specific. It's not cell specific. They pretty much inhibit all cytokines, all inflammatory substances. So they have more, it's like a shotgun. Okay, let's put it that way. Corticosteroids is like shooting the problem with a shotgun. So you have a lot of collateral damage, which is not necessary. But leukotriene antagonists or inhibitors, they only target one. So this is more a more precise targeting, okay, of the disease. Complications, I already mentioned the cor pulmonale, the right side heart failure. Others are related to the treatment. The steroids will have consequences like hypertension, glaucoma, hyperglycemia, osteoporosis. What else? We have peptic ulcer formation, GI bleeding. Right, so there's so many complications associated with steroids. This part here, this is for asthma, so never mind that because we are in the asthma section here for the treatment. Okay, let's go back to, oh, wait a minute. We have to do the inhalers also, how to use them. Okay, so here is, all right, an MDI. You'll also observe some patients with COPD. You would think that they've been on these inhalers for a long time, that you assume they know how to use it. But if you take the time to observe, some of them don't really know how to use it. And you'll wonder why they're admitted to the hospital frequently, because they're not using it correctly, so therefore they're not getting the medication. So the medication is supposed to be in their lung, not in their mouth, which is the result if the patients don't use these correctly. So the medication tends to be in the mouth instead of deep into their lungs. So this is how you do it. Remove the cap and shake the inhaler. Breathe out gently. Put the mouthpiece in your mouth. And then, which should be slow and deep, press the canister down and inhale deeply. Hold your breath for 10 seconds or as long as possible, then breathe out slowly. Wait a few seconds before repeating steps 2 to 4. So these patients may have 1 or 2 puffs. So if it's the same puff of, no, 2 puffs of the same medication, they have to wait at least 1 minute, okay, between puffs. Don't take it one after another with only seconds apart. Okay, so there should be a 1 minute space in between um, puffs of the same medication. If you're taking 2 different inhalers, then there should be at least 5 minutes between different medications. Any question? So this will, just like when you're giving eye drops, let's say you're giving two drops of the same eye drop, you have to wait at least, um, there should be time. Usually it's 5 minutes, or some books say 1 to 2 minutes between drops. But if it's 2 drops of the same, if it's 2 different medication, there has to be at least 5 minutes between those eye drops. Okay, so the same thing here. The recommended technique is using an aero chamber here. This is an extension. So this is where the patient's mouth is. So instead of this one wherein the mouthpiece is inside the patient's mouth, this one is, you have this chamber here, which gives the patient more time, because when you press the canister, the medication is aerosolized and circulates in here. So the patient now can take their time when they breathe it. Sometimes the chamber device is not, covering the whole face like this. The mouthpiece is the same as this mouthpiece, but you still have the aero chamber though. So instead of having this mask, you'll have a mouthpiece sticking out here, and that's where the patient breathes in. Either way, the patient still gets more of the medication. So this is good for patients who don't know how to use it, meaning this one, this canister and this simple inhaler. If they have problems timing when they press and when they off using air chamber, again, the medication floats around here for several seconds, so they can take their time breathing in, and as a result, they get more of the medication and they get less of these unnecessary hospitalizations. they'll have less what is this? Less exacerbations. Here's a few tips. If you hear a whistling sound, that means you are breathing in too quickly, okay, through the air chamber device. So that's your warning. You're breathing in too quickly. Any questions on how to use it? The only difference here is, of course, this one has a propellant. Okay, so when you, it's designed that way. So the tip here of the canister, when you press on the canister, the tip will make the medication spray. Okay, because the canister is pressurized. So therefore, there's a propellant. So the medication will be sprayed, and all you have to do is inhale that sprayed aerosolized medication. In the case of a powdered medication, it does not spray. So you have to literally suck in the powder. So this is an example of a okay, let's use how many seconds? Okay, 1 minute. Can you see the YouTube website?
Yes.
Okay.
Yeah.
Okay, so this is a dry powder inhaler compared to meter dose spray, which by the term itself is spray. The particles are larger, so they don't have the same reach as a powder. So powder is in a more finer particle, so they can get even deeper into the lung. That's not how she did it. Okay, it should be faster and deeper like she did, because um, there has to be a certain level of speed here. So you really have to suck in. Like, how do you snort your Coke, Richard? Do you do it slow or fast? Richard?
Richard is here.
Yeah. How do you inhale your Coke? Do you go slow or really fast?
I think you go slow.
That's not it. Nicole, how is it done?
Fast.
High
Oh,
class.
do you use a dollar, or what do you use?
I like to feel rich, so I use like the $100 bill I have.
Okay.
Just snort super fast.
All right. That's the way to do it. Of course, this one is not snorted though. So this is inhaled through the mouth. Let's watch something else, because that chick is not doing it right. Let's try this German chick. Okay, that would be the only thing I would not recommend doing because she exhaled too close to the canister, so it will moisture might enter there and then it will clump the powder. So that wasn't. Maybe it's better if you exhale, away from the disc. Okay, it's not necessary to pinch your nose, but if you want to, that's fine. But you won't see pinching your nose on any of the steps on any textbook. So this is just her personal recommendation, but it works. Any question?
No.
Okay. Before we go on a break, let me just see if we covered everything. Oh, one more thing on breathing exercises. All All right, please read the nursing care on your own. This summarizes how the medications are used. And here we have the breathing techniques. So we have pursed lip breathing, and also we have diaphragmatic breathing. But the more frequently taught breathing technique is the pursed lip. So the pursed lip prolongs the exhalation phase of breathing, because normally when we breathe, it takes us 1 second to inhale, another 1 second, or maybe 1.5 seconds to exhale. In pursed lip breathing, you extend it, so it becomes 1 second to inhale. You can extend the exhalation phase up to 4 seconds, so it'll go, the I to E ratio becomes 1:4. So that is pursed lip breathing. So how they teach this is smell the flowers and then blow out the candles. Okay, that's a phrase I frequently hear in the hospital. So they inhale through the nose, and then as they exhale through pursed lips, they count 1, 2, 3, 4. So those are your 4 seconds there. Okay, so the exhalation should be at least twice as long as inhalation. So that's pursed lip breathing. So how does this benefit the patient with COPD? Well, remember, they have those damaged alveoli, which retain so much CO2. So meaning there's so much residual air there from the previous breath and gets stacked on with every succeeding breath, right? Meaning with every breath you take, you have even older air there from the previous breath, which you were not able to exhale. So as a result, you have a lot of dead space in there, meaning a lot of air which doesn't contain oxygen. They're all CO2, and we don't know how old they are there. So when you do pursed lip breathing, therefore you're extending the exhalation phase. So you're actually trying to expel more of that CO2. All right. So therefore, that's the purpose of pursed lip breathing. Please read this safety alert. This has to do with the not giving too much oxygen to COPD patients. This is the theory behind it. You've learned this probably in fundamentals, right? That you can't give these patients so much oxygen. So this is the theory behind it. And I'd like to emphasize that it's only a theory, okay? There's really no proof of this actually. I'm referring to patients who are intubated and on a mechanical ventilator, because those patients, whether they have COPD or not, we are giving them a lot of oxygen. So again, this is only a theory, all right? But you follow the theory. Probably not when it comes to mechanical ventilation. And that's it. All right, let's take a break. Come back at 10:55. Sound good?
Sounds good. Thank you.
All right.